Yes. Dr. Neelam, we can start now. I'll introduce you first. Yes. So, good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. And today we have a very eminent personality in Dr. Neelam Mohan. It's always a pleasure to introduce Dr. Neelam. She is a pediatric gastroenterologist, hepatologist, and she has many string of qualifications like DNB, FPGS UK, FIMSA, FACG USA, FRCPH, FIAP, and AMPH from ISB. Currently, she is Senior Director, Department of Pediatric Gastroenterology, Hepatology, Liver Transplantation at Medanta Medicity, Gurgaon. She has several awards and achievements to her credit. First being Dr. B.C. Roy Award, then Distinguished Teacher Award by National Board of Examination. She established the first department in country of pediatric gastroenterology, hepatology, and liver transplantation. Established first training program in India in her specialty, and she has figured in Forbes magazine in 2021 as powerful performer. She has held many positions. Few of them are President, Commonwealth Association of Pediatric Gastroenterology and Nutrition, Academic Council member of Indian College of Pediatrics IAP. She is advisor to PMJ Yojana, advisor to National Board of Examination for Pediatrics. She has held several organizational posts also, like Indian Society of Pediatric Gastroenterology, Hepatology and Nutrition from 22 to 23 as president. Several organization academic posts in Indian Academy of Pediatrics in her specialty. And she has tremendous amount of academic contributions, like more than 1,000 presentations in India and more than 200 international presentation. She's written, contributed 50 chapters in various books and more than 120 index publication, more than 300 electronic interview on national TV, more than 200 press interviews, contributed to several national and global practice guidelines in her field. It's very lengthy CV, but at my personal level, I would say that Dr. Neelam is a very popular speaker amongst pediatric fraternity, very well known across the country and at international level. And we look forward to a very informative talk from her on the subject of fatty liver. And as we have mentioned in the flyer, it's a undermined disease. People do not either recognize it as a very important condition or often are not aware about it. She is going to address this issue in both the age groups, pediatric adolescents as well as adult groups. So over to Dr. Neelam. Thank you for joining us.
Thank you so much, Dr. Satish, for the introduction, and I'm so grateful to Saturday Club of Baroda for this opportunity. And my favorite hero is Shah Rukh Khan. You know the reason I like Shah Rukh Khan? Because he was the guy who said, "Bade bade shahar mein choti choti baatein hoti rehti hai, Senorita." So that's how it happened with Senorita. That it's not working right now. So I'm going to start the lecture extempore. Are you all able to see me?
Yes, yes. We are able to see you. We are able to hear you well.
Great. So the topic that has been assigned is fatty liver disease. Let's start basic with the definition. What do you mean by fatty liver? So first of all, we are talking about the liver. Liver is one of the most beautiful organs of the body because it performs maximum functions. Like it's supposed to perform more than 500 liver functions, chemical reactions, etc. That is being performed by the liver. And we all know right from digestion, bile production, synthesis of proteins like coagulation factors, whatever we are eating, the drugs that you take, and alcohol, drugs, everything is metabolized in it. You don't eat all the time because is the liver which stores it in the form of glycogen and releases it as and when you want it in the body. And then it filters the toxins. It also stores vitamins and minerals, and that's why it's a very important organ. We have the hepatocytes and the toxins within the liver. So when the hepatocytes, normally also we do have some amount of fat in the liver, but when this fat goes to more than 5% or so, we call it the liver. You might find definitions nowadays 5 to 10% of it when it gets into. So what is NAFLD? NAFLD, or the non-alcoholic fatty liver disease, these terms were coined late in 1970s when people said that you had the fat in the liver, which was more than the 5% of the hepatocytes and steatosis, but there was an excessive, there was either an evidence of insulin resistance in the body, and most importantly, you had excluded other causes of fatty liver disease like alcoholic fatty liver disease in adults. So that's how the term was NA, non-alcoholic fatty liver disease. And in children, it was almost in late 80s, the first case of fatty liver disease was described, from where we marched on so rapidly from 1983 when they described it as a fatty liver disease. And recently, over the last 1 decade, we've realized that this term is not appropriate for children and even maybe for adults they're looking into. And so there have been a lot of papers which are justifying that it is time that we don't use the word non-alcoholic, because you would agree, children, we don't use alcohol. So we now marched on to call it as the metabolic fatty liver disease, or MA. M for stands for metabolic, A for associated, and FLD for metabolic associated fatty liver disease. And sadly, this is the most common cause of fatty liver disease in children. Can you pin me so that I'm seen by all?
I already pinned it on my laptop. What I suggest to everybody that you can click on Dr. Neelam's frame, and you can go in the option of pinning her. So you will be able to see Dr. Neelam well on your screen. I already done it on my screen, so others may do that.
So this is what it was called as the metabolic associated fatty liver disease. And I was trying to impress you all by showing a lot of papers. And recently the consensus that I'm truly humbled to share, that there was a part of the global forum which we're trying to talk about this. And we have a group called the FISHPAGAN, which is the Federation of International Society of Pediatric Gastroenterology, Hepatology, and Nutrition. And as a president of the Indian Society and president of the Commonwealth Society, I was a part of it. We were writing the global guidelines on fatty liver disease, which is going to be soon released. And the one paper has already come out, which says that now we should change the name from NAFLD to MAFLD, both in children and in adults. Adults also use this terminology. The Asian Forum was one of the first ones to call it. Now, if I tell you all fat in the liver is due to NAFLD or MAFLD, would you believe me? Your answer would be no, because all fat in children is not NAFLD or MAFLD. So there are a lot of other causes of in the liver in children, and that's what makes a life more difficult than in adults, because you may have not only hepatitis C as your cause or Wilson's disease as the cause, and certain drugs, etc. Even drugs like aspirin, anti-tuberculous drug, glucocorticoids, methotrexate, sodium valproate, tetracycline, these can also have an impact and give rise to fatty liver disease, but more importantly, other conditions that you can see in children, severe malnutrition, which is undernutrition, and obesity. So both the end of the spectrum can have fatty liver disease, celiac disease, certain cases of IBDs and all. But in general, the other storage, metabolic storage disorders like hereditary fructose intolerance, mitochondrial disease, fatty acid oxidation disorders, these can give rise to. So if I talk about fatty liver disease more than 5 years of age, usually I would have excluded the other metabolic causes that you would see. So therefore, it is a must if you find fatty liver disease in younger children to definitely take the opinion from an expert and rule out the metabolic causes. But if you are talking about it above 5 years or above 9 years of age, then we know we are predominantly talking about the metabolic associated fatty liver disease in them. In general, I would say that the global burden of fatty liver disease in children is in less than 5 years. It is 39 million children are overweight and obese, and in more than 5 years to 19 years as adolescent, more than 340 million children are overweight and obese. This data was given by WHO recently, and that is shaking us up. And the purpose of this talk today at the Baroda Club was to impress you all how rapidly where India was talking about undernutrition all the time, and now we have marched into a double burden with not only undernutrition on one end, the other end of the spectrum, we are rapidly marching into overweight and obesity in children, giving rise to fatty liver disease. Now, if I talk about the prevalence of fatty liver disease in obesity, so overall population, you can say 7 to 10% in children. In adults in India, in general, we say 1 in 3 practically you may have a person with fatty liver disease. Now, we Indians sadly are the thin, fat belly Indian. Overall, our arms and legs may be thin, but most of the time when we become fat, we accumulate fat in our abdomen. You all would agree, whether men or women, whenever you see, it is that most of the time it is the tummy which is the fat you're putting on in your abdomen. So we are called as the thin fat Indian or the thin fat Asian, and that is the problem with our genes. It is said that probably our genes have been attuned to storing, fat in terms of need. And also, we have seen that premature babies, they also tend to get fatty liver disease and obesity because of the same hypothesis, the Barker's hypothesis, where you tend to store what you have in term just in case you need it when desired. So with that hypothesis, the body was storing it in your body, and that's why we get that similarly. But if I take only overweight and obese, what is the prevalence in them? In them, in Asia, 52% children would be MAFLD, which is metabolic associated fatty liver disease, the new term. They would be 52% if I just look at the childhood obesity. And in the Americans, it's 30%, South Americans 40%, and I didn't start. Europe is fortunate, it is 25%. So while you see 1 in 4 European obese child having a fatty liver, you would see 1 in 2 child with a fatty liver in Asia. So this is the problem with our genetics also that we are talking about in this. So if we talk about overall prevalence of fatty liver in adults, I said in Africans, luckily, they have a lot of muscle mass even if they are obese. So they have only 14% of their adults would be, even if they are obese, 14% would have fatty liver disease. But if you look into Middle East, then we would be 25% would have fatty liver disease in them. Now, the global prevalence of NAFLD in children, when we are, this is what we is globally, it is getting very popular, and we are marching to more than 10%. Even children are getting obese. So, what is the pathophysiology? I just want to make as maths for you all, because if you see the complicated diagram, you'll get really confused. Oh my God, what is this? Explaining, but in simple words, what you take is your energy, what you take out is your energy expenditure. So your energy intake, if it is more than the energy expenditure, then you get into a positive energy balance. And this positive energy balance, when it gets over, then the adipose tissue gets saturated. When your adipose tissue gets saturated, it gives rise to abnormal fat distribution in the fat cells. Once you have adipose tissue in the fat cell, it gives rise to inflammation. This inflammation can get, that means it stimulates the what we call as the cytokine surge, and based on that, this inflammation eventually gives rise to the systemic inflammation, and that's how you get the atherosclerosis, the systemic inflammation. And when I said adipose tissue in the fat, there is free fatty acid release, and that's how you get the fatty liver. So this inflammation, not only with the systemic inflammation, this inflammation within the liver is called as the NASH, which we used to call as non-alcoholic steatohepatitis. So inflammation will start once it accumulates. So first step steatosis, second step inflammation. So it is called hepatitis. Third step, this inflammation, when it heals, it gives rise to fibrosis. So there is fibrosis. Fibrosis, if it keeps increasing, it gives rise to cirrhosis. So that is how fatty liver disease, inflammation, fibrosis, cirrhosis. This takes time. This takes usually to 1.5 decades, 15 years or so. But when we are talking about children, now we understand that this is what is happening in childhood and it is marching over to the adulthood. So if I can do something in childhood, then that would be the best way to prevent it. So this is what we say, but somebody can question me, Neelam, can you see it in a lean child? Right now, let us forget about it. There are conditions in lean child, some genetic, but let's not discuss. Let's focus that predominantly we are talking about the overweight or the obese and overweight, which is giving rise to fatty liver disease, steatosis, hepatitis, and cirrhosis. But yes, the lean fat is also reported in a small proportion of patients, both in adults and in children, which is predominantly related to genetics rather than the environment cause. So when I said this, so that is very simple. So what is the pathophysiology? Pathophysiology is this, what I said, the accumulation of the fat. So how does this occur? The genetic and environment together. So these two together is giving rise to this distribution that we are talking about. And in addition, we talk about certain other factors in them, like, for example, the premature babies that I was talking about. So these are the other factors which will give rise to, and then the metabolic X syndrome. What do I mean in metabolic? So when this fat gets deposited, it is a precursor for the insulin resistance. And insulin resistance itself can give rise to, because it is the liver which gives rise to the, so the hypothesis now that they are talking about what you develop diabetes, etc. Not only the pancreas, it is the liver which is also responsible, because once like you have a surge when you eat sweet, the sugar levels goes very high. So more insulin is released to tackle it. When insulin is released, and then your sugar level goes down. Once your sugar level goes down, then the body will either try to, you will have a desire or urge to eat more sugar, or the body will try to release sugar, and eventually the insulin resistance will happen. So it is also seen that males have a higher incidence of 2:1 as compared to women in this. So we talked about the age. We older age has a higher incidence because this is progressive. We talked about the sex. We talked about the genetic. We talked about the environment where you're taking more. And when we talk about the environment, it is the diet and the exercise that you're living. And then we talked about the epigenetic factor. The epigenetic factor was what I said, the prematurity, small weight. These are the epigenetic factor. Now comes the another hypothesis about your gut microbiota. We also know that we have 1,000 times more cells of the microorganisms in our body than our own body cells. So when our gut microbiota is disturbed, that itself can give rise to fatty liver disease. And there's a lot of studies which have shown that there is a direct correlation. We used to think whether the gut microbiota changed because of obesity, but now we understand that obesity is also changing the gut microbiota, and change in the gut microbiota is causing to obesity. So we actually took the poo of small mice and put it into obese child. So we took one thin child, one obese child, and we took the poo and put it into the fecal transplant into two mice, and gave them the same diet and same environment. But the child who got the microbiota of obese became the obese, and the thin continued to be thin. So there is a hypothesis that the gut microbiota gives rise to obesity and fatty liver disease also, and this is why we are talking, because it may have an impact on the therapy itself. So then, even in children, the metabolic X syndrome is seen. Therefore, what is metabolic X syndrome? The fatty liver disease, the diabetes, the hypertriglyceridemia, the atherosclerosis, the polycystic ovary. So these are all part of that. Similarly, in children, when we are talking about, of course, hypertension, when I talk about atherosclerosis, in that 50% of the children have been shown to have hyperinsulinism in NAFLD, and there is prevalence of 10% of hypertension, 12% of hyperglycemia, 24% of hypertriglyceridemia, etc. And more than 50% of children in the Kashmir study of urban rural children showed a metabolic X syndrome that we talked. And there was a, what is the progress and what is the prevalence of this in India? So we have shown that where we were talking based on the ultrasound studies and subsequently the elastography, right from 7% to as high as 25% in the urban school children, like in Delhi, etc. It is as high as 25% of the children are getting overweight, obese, and having fatty liver disease on ultrasound basis. So this is really alarming for us to understand that, yes, not only urban, but studies in the rural also showed to the tune of 7 to 8%. So it's a spectrum. Then you may ask me that, Neelam, you said that it takes 2 decades or 1.5 decades to progress. How do you say that? So there have been some studies. There was a beautiful study which came from 122 children. They did biopsies. This is one of the first studies where a biopsy was done earlier, and subsequently biopsies were done. And they showed that fibrosis marched and progressed from 20 to 34% in this biopsy. So therefore, it shows that there is progress in that. And younger children with more severe fibrosis at the time of biopsy progress rapidly. And when they have genetic tendencies, they may overweigh the environmental factors. So whether this can be reversed, I'm going to talk next. So another multicentric study, which was the 20 years follow-up of children. This was a retrospective study where they showed that children with NAFLD had 13.8, virtually 14 times higher risk of dying or requiring a liver transplant than general population. So yes, my dear colleagues, what we are saying is that in case you have fatty liver in children, you will march and progress to have fatty liver in young adulthood. And if you acquire fatty liver in adulthood, that also progresses over 1.5 to 2 decades. And this progression is dependent on the other factors. If you were taking alcohol or you continue to have genetic predisposition, metabolic syndrome, other factors, then your progression would be rapid. And the commonest liver disease globally is now fatty liver disease. The commonest cause of liver transplant globally is fatty liver disease now. So we used to be doing alcohol, hepatitis B and C, and now fatty liver disease because we have treatment for B and C. So B and C is reducing, fatty liver disease as the cause is increasing, and fatty liver disease, alcohol, and cancer. These are the 3 most common causes of liver transplant in adults. And in children, still it is the cholestatic liver disease, acute liver failure, metabolic liver disease. But the indication of liver transplant in childhood for fatty liver disease is minuscule. Very few cases have been done because if they started very early in life, they would have matched before 19 years to an end-stage liver disease. Otherwise, the brunt of this progress is there in adulthood that you're going to see the brunt of this. So now let us come to how do you diagnose? So the diagnosis is, should I go in for an ultrasound? Ultrasound will show you the fatty liver disease, but it is not very reliable. It is dependent on the who's doing it. So it is little bit observer dependent. And yes, you can classify into grade 1, 2, 3 liver. The early stages you miss it. Second is liver enzymes. So liver enzymes are also a screening modality where you see if your liver enzymes are increased and you don't have any other causes like alcoholic disease and you're overweight or you have metabolic eggs, then the chances of your liver enzymes increase are due to MAFLD, MAFLD. Third, elastography. What is elastography? Fibroscan in adults or ARFI in smaller children and obese smaller children. We do acoustic radiation, RF, which we call it. But the third is the MR elastography. MRI elastography is very sensitive. It really picks up, it tells you which part. So I said ultrasound, then I said elastography, which is Fibroscan or RP. Fibroscan more often in adults and RP in younger children, less than 5 years or too obese, where Fibroscan is giving us some issues. Third was MR elastography. But you would all agree is I can't subject everybody to an MRI. It is more for academic reasons that you're doing them, or that when we do liver transplant in the donors, my donor, whoever is donating, mother, father, uncles, relatives, in the donors I want to rule out. So we go in for a MRI because it will also tell you, quantify the fat in the liver, 5, 7, 10, left side, right side. It helps in the quantification. Neelam, do we have some blood tests which are biomarkers for fibrosis? I think leave it. It is these blood tests and biomarkers are more for academic reasons. Right now, on a doing it for diagnosis is not yet what we've achieved. Should I do a liver biopsy? Yes, liver biopsy is the gold standard. It can tell you exactly what is the fibrosis, whether the etiology is fatty liver or the other causes. But then you will have a reason to do the biopsy and leave it to experts, a pediatric hepatologist and experts when they do. So we do have guidelines from North American Association, European Association. When should you do a biopsy? Especially in smaller children, as I said, we have metabolic causes. So less than 5 years, I need to be sure that it is not all fatty liver disease due to metabolic. And in older children, more than 9 years with abnormal enzymes or with family history or raised alpha fetoprotein and a family history of SCC. And these are the patients where I would actually want to go in for a liver biopsy in them. That these are the modalities that we do. So in children also screening is quite often by doing the liver enzyme ALT. It could be used. Persistently increased ALT for more than 3 months, twice the upper limit of normal, which is around 25 that we take in children. For boys, 22 girls. So average 25, that's the guidelines which has come about from the North American Society or the European. Even if you go up to max 30, so anything which is twice the upper limit of normal ALT for that child, persistently there for 3 months, they should be evaluated for metabolic associated liver disease. Once you rule out the other causes of chronic hepatitis, whatever B, C, Wilson's, autoimmune, etc. Once you rule out, then you do. And routine ultrasound is not recommended as a screening test for MAFLD in children due to inadequate sensitivity and specificity. And we often like to go for elastography. Fibroscan is now a newer probes are also available for small children. Those who don't have those machines for the small children probes, they should go for an ultrasound probe, which is called as RP. So now, dear colleagues, I would be coming to the last stage, the management. So the goal of your management is to decrease steatosis, decrease inflammation, reduce fibrosis. So this is my goal. Number one. What is the goal? Number two, by working on the liver, I should reduce the complications which are extrahepatic, which is diabetes, hypertension, cardiovascular. Because you may die of your other complications, but then, as I said, the insulin resistance, etc., issues are occurring thanks to your liver too. So, what is the management? The answer is lifestyle modification. Lifestyle modification is the management, which is the diet and the exercise. So we did some studies where, so what is the amount of fat I need to reduce for getting my fat? This is the question I am always asked both by my adult colleagues and parents. So if I reduce 5 to 7% of the body weight, the steatosis will improve. But if your liver is already into NASH, that is steatosis associated with inflammatory cells or fibrosis, then I need to reduce more than 10% of the body weight to reverse it. So that's the beauty, my dear friends. Not only can you prevent it, but you can reverse it if you work with it in the early stages. So steatosis can be reversed, inflammation can be reversed, early fibrosis can be reversed. Once you have cirrhosis, we can't do it. So therefore, we are talking about lifestyle management, reduction of the body weight, 5 to 7% of your body weight for reduction in steatosis, nearly 10% of your body weight for reduction in inflammation and fibrosis. Then what is for children guideline? So lifestyle modification. What is vitamin E? Vitamin E is an antioxidant It works as an antioxidant. People have tried that. Ursodeoxycholic acid is not shown to have any impact on fatty liver disease. Vodaminine 400 mg for couple of months have been shown to have some liver disease, but now we are marching to the newer drugs, the metformin and the omega-3 fatty acids, vodaminine. These are the medications with the metabolic effects. Then we have medications with anti-inflammatory effects, which is the elafibranor and obeticholic acid. This obeticholic acid is called the FXR ligand, which improves hepatic fibrosis, and it has been FDA approved for adults to reverse the fibrosis by obeticholic acid. And phase 3 trials have been done in children where promising results are being seen with this, which will reduce the inflammation and fibrosis. And other anti-fibrotic newer drugs are also available, like Cilon-Citral B, and a combination of these drugs are there. So before I end, I would just like to impress on you about the diet. What you should reduce is the processed food, the sweetened beverages, the refined flour. That means maida, packaged food, preservative food, sweets, cool drinks, cokes, anything which is what we keep talking about, your overweight, obesity, the same thing I have to talk. So more legumes, pulses, fruits, vegetables, salads, nuts, seeds, and antioxidants like fish, surplus, the seeds, olive oil. These are all the Mediterranean diet, what we call, are all good. Second is exercise. What is the minimum exercise you need? Minimum is 150 minutes of moderate intensity aerobic exercises over a week, or 75 minutes of vigorous activity, or an equivalent combination of moderate to vigorous. What is preferred is to undertake 300 minutes of moderate activity. That means almost 5 days a week, 1 hour at least of moderate activity in a week. And if you're not able to do that, then twice as much, 150 minutes of, so 300 minutes of moderate or 150 minutes of vigorous. That means 300 was 5 days a week, 3 days a week of vigorous activity, and that you need to do. To muscle strengthening exercises 2 to 3 days a week, and flexibility exercises is yoga. So weight reduction. So there was a beautiful study where two people reduced weight equally, cohort. They reduced weight same, but this reduced with diet and this reduced with diet and exercise. So the one group is reduced both with diet and exercise had a better impact in reduction in fatty liver disease, inflammation and fibrosis than that with diet. And that is why I'm harping about not only weight reduction, I said muscle strengthening exercises, activity that you need to work upon this. And your remember, fat even in a child should be less than 25% calories, saturated fat less than 7%, protein 15 to 20%, carbohydrates 40 to 50%, avoid fructose, and trans fat should be totally removed from your diet that you do. Eventually, with a reduction of the weight loss of 23% weight loss, they showed that steatosis could be completely reversed too. So 0.3% of the weight. And then the inflammatory cells, natural solution, etc. more is there. And please don't forget that stress management and sleep is equally important. Studies have shown that you tend to get more weight due to lack of sleep because your healing occurs during night. And therefore, not only was the diet and exercise, but your sleep is very important in reduction, and your relaxation, which will release the best of hormones. So these are equally important. And there was a study which talked about, 2 to 3 cups of coffee a day did have an impact on reduction of the fatty liver. So is there any role of bariatric surgery? Not so much in children, and now even in adults, there has been new introduction of newer drugs. You have heard about it, and I can take the question. Seraglutide is also available in India. So liraglutide and seraglutide are the newer kids on the block, which we are talking about reduction of the weight because it acts on your satiety center and you don't feel like eating it. These are the ones which are talking about. And Lilly, as well as there are these products are now available in India and in adults. Don't forget, you need to do your lipid management, you need to do your hypertension management, you need to do your diabetes management too as you're going in the journey. And you can reverse it if you do the weight loss. And to sum up, how can you keep your liver healthy? You can through your diet, exercise, yoga, relaxation, sleep, all this, no alcohol, vaccination in children against hepatitis B, A, and control of weight, diabetes, etc., healthy lifestyle. You can do it. And please don't forget, in a country like us, herbal medications. We've had so many children who have taken Ayurvedic medicines and they end up with a very bad liver disease too. So remember, at least the drugs which are proven through phase 3 trials and studies are better than what you don't know about. Thank you so much for this talk and bearing with me without my slides.
Thank you, Dr. Neelam. Wonderful, as was expected. With or without presentation, an expert can talk on the subject without any hesitation. So thank you for very informative talk. A question for pediatricians regarding when do we actually start screening these obese children for fatty liver?
So the first thing is, in obese children, you can go in for a liver enzyme. A lot of people say that the liver enzyme could be a very good marker for checking. And if your liver enzyme are 2 times the upper limit of normal, then that is a worry that should you look into it. And I said that especially experts like us, we go in for elastography or a fibroscan, which tells us to reading CAP, which talks about the steatosis, and KPA, which talks about the fibrosis in children. You would not have so much of fibrosis. You will have predominantly the CAP fat steatosis. But of course, wherever not available, ultrasound, when they talk about it, that can detect the fatty liver.
Right. So incidentally, we
have a family history of obesity, fatty liver, and a child is overweight, obese, then these will make you. And some few facts we all of you know that an adolescent obese has 80% chances of an adolescent adult. And if one parent is fat and the child is more than 5 years is again getting obese, the chances for this child to get is 50% is going to get. And if both parents are fat and the child is getting fat, then it is a very high tendency. So you need to look into those lots.
I was just trying to share that incidentally, last week only, we had Dr. Seal Shah, who is a local radiologist in Baroda, and he talked a lot about elastography. So my question again, sorry for repetition, but we see a lot of boys and girls, adolescents who are either overweight or obese. Should we all subject them to elastography?
See, that's what I think. The guidelines abroad are very clear. They do not subject it like this. They would suggest that you do the liver enzymes, and if the liver enzymes are getting abnormal, then you subject. But in India, what is happening is the 2/3 of the care is in the private sector and a quarter of the care is in the government sector. So when we make guidelines, it is different. But for an individual, like you are paying for your, so then you say, I want to know. So you please understand what I'm saying is, then in that case, for an individual, he or she wants to know whether there is, and sometimes I'm being very honest, it gets very easy when you're talking about an overweight or an obese child. The parents do not accept it the overweight especially. They think that the child is just, unless they put it on a growth chart, they never know that the patient is overweight. It is the growth chart which impresses the patient is overweight. And even in obese, there is a denial in them. They use the word "Mera bacha healthy hai." So there is a denial in India to overweight and obesity in parents. So sometimes by doing an ultrasound which starts showing a fatty liver or fibroscan, you're able to impress onto them. And when you had overweight parents, and then it gets very easy to communicate. But will it make an impact that I'm going to change my treatment? As I said, ultimately, you're not going to do a liver biopsy. You'll do a liver biopsy only if the enzymes were normal for more than 3 months and you've ruled out other causes of abnormal liver enzymes, and you want to be very sure. First, a lot of people say that you lose weight and see if your enzymes improve with reduction in weight, then it means that it was a fatty liver disease. But only otherwise, when you're stuck, that's the time you should do a biopsy.
Thank you. Any other questions, comments? There are physicians also here. Yes, Dr. Hemant.
Excellent presentation, madam. And we got the gist of the message. As a student of gastroenterology, I just like to mention that there was a paper that the easiest way to screen is to find the mean platelet volume. That was used in a paper from Turkey, and Indian Journal of Gastroenterology editors also easily lapped up about a year back. That if the mean platelet volume is more than that NAFLD, that is the fatty liver, is progressing to NASH, that is non-alcoholic steatohepatitis. It is very irreversible and causes cirrhosis. And people are, madam, finding bacterial endotoxins, or they are finding genetic predisposed, what you call very important are epigenetic factors, like you told about Maida and this thing. They change the bacterial gut, and as a cliche, everything is blamed on bacterial gut, but answer must lie on the, as you said, lifestyle changes.
It is very easy said than done, and there has been a lot of understanding in the last decade. If you know what we were talking about the fatty liver disease, and the understanding has come out very clear. The only magic thing is the weight reduction now, which can reduce your reverse your fatty liver disease, inflammation, and fibrosis. But how to do the weight reduction? It's not so easy. I want to reduce 4 kgs. Am I able to reduce the 4 kgs? Is it so easy? That is becoming an issue in our lifestyle. So when we talk about the weight reduction, I said that we have shown that it is not only the diet, but you need a good combination of diet and exercise together. And you need at least 7% of your body weight, whatever you wear. If you wear, say, 100, so then it is 750. So I'm just giving you a percentage of your body weight reduction, or 10% at least, to start reversing the fatty liver disease. So that is very important. And those who are overweight, obese, and have a bad lifestyle, they will reduce very rapidly, because once you put them into, you know, a diet, which is what we are talking about, how you need to be taking, you know, because we are very bad in a diet. Though we say Indian diet is very good, and we show the plate of thali with the roti and the chawal and the sabji and the dahi and everything. But having said that, if you look in the real diet, I mean, you're supposed to eat the 2 meals in the 2 meals, except the breakfast, the 2 meals, you're supposed to eat 50% or more with vegetables. Are we doing that? So I think what is really good is that we need to change. I mean, yesterday, I mean, I wish I could show that photograph. I was seeing one of my colleagues. He married an Australian wife, and so his food is a big box, or a plastic box he gets, which is full of like there were salad leaves, and there was olives, there is cheese, there is chicken, there is egg, boiled chicken with, but everything was there, but there was no cereal. So that is the way forward. We need to understand that your carbs have to be reduced to as low as 45% to 50 and increase your proteins in that. And it's beyond the scope of this talk, but sometime, I mean, what about those intermittent fasting? But so based on your blood group, based on your style, yes, the only intermittent fasting has been shown. So there was this study which came and it has been hugely criticized because they said that the people with intermittent fasting had higher, an abstract it was, that had an higher incidence of uh, cardiac problems. That was just an abstract. Recently, everybody saw it. And that was totally criticized because it just gave a false image. There was a lot of people, they said that that was not appropriate the way it was looked into. Still, one of the best things that they've seen in reversing the metabolic X, is the intermittent fasting, where that is one of the finest way if you have insulin resistance. That's what they're talking. So you need to identify if you are based on your Homer calculation, fasting insulin and fasting glucose and those calculations, and then that is the way forward for them. Otherwise, for people like us who find it very difficult to go on intermittent fasting, we should behave ourselves with good amount of exercise, with sleep, and a healthy diet, which is more of vegetables and fruits and salads in it.
Correct, madam. Very important.
And
Now,
then having talked about the biomarkers, see, बहुत कुछ आया, प्लेटलेट देखो, ये देखो, it's like पर्दे के पीछे क्या है, नहीं वो हिल रहा है तो वो रस्सी है, हवाई तो रस्सी हिली, सांप है. अब आजकल के जमाने में पर्दा हटाओ और देखो कि सांप है या रस्सी
we
है.
need to have this trial.
नहीं, I'm just telling you, just let me finish. तो वो पूरे हाइपोथेसिस गायब जमाने ये सब देखो, ठीक है ना. अगर आपको वो है तो यू जस्ट गेट अ वे, either an ultrasound or a fibroscan. 1200 रुपए में आजकल everything is possible. Ultrasound is cheapest in the country. If you go to US, UK, getting those things are very expensive. In our people, if you do an ultrasound upper abdomen, not complete, it is half the rate they charge you. So it's like very cost effective to get your fibroscan or an ultrasound to see which way you're marking, and I can give you a figure which you can talk about. Yes, what you said was very beautiful. You said, Neelam, I'm not asking about fatty liver. I want to know, has it gone into inflammation? I want to know, has it gone into fibrosis? So for fibrosis, again, fibroscan KPA is better. And you can't get fibrosis without inflammation. Inflammation only way. So if you have your KPA, मैं platelets देखो, मैं ये देखो, straight away मेरे को वो दिख रहा है. हाँ, वो नहीं है, मेरे liver enzymes बढ़े हुए हैं. Then you look into the other parameters to say which is NASH with that. I appreciate what you said about that.
Thank you. Thank you. Very
fructose
elaborate and
causing
informative.
fatty liver. Fructose causing fatty liver with so many
Yes,
fruit juices and
absolutely. ये हम सोचते थे कि फैट नहीं खाना, और जिंदगी भर हम यही सोच के जीते रहे पिछले 25-30 साल. And then came the era to understand that the whole game was not fat, it was the sugar.
carb.
Sugar was
And fructose.
addictive, fructose, sugars, beverages, cola drinks, addiction was this, and that gave rise to fatty. Very good question. So that the hypothesis which I said, and I spoke about it in NDTVC and VC and all, how that is the culprit. The insulin resistance is the main culprit. Get it straight across. And that is happening because of the diet, more sugars and all. It gets into your liver, a rapid rise. So insulin increases, the rapid low in the glucose, and that's how the body gets into the insulin resistance.
Muscle, building muscle is a very important thing.
Yes, yes. That's why I said exercises combined will have a better effect than diet itself. Diet itself.
Muscle is the second liver.
Gee.
So, thank you, Hemant, for that.
Is there any role of seraglutazar, that is a drug, especially in children?
Yes, so no, not now in children, sir. We have not get in adolescent trials, yes, been going on about using in adolescents. So there are a lot of papers which are coming about obesity and use of seraglutide and case-to-base basis people have used in adults, in adolescents, but not in young.
The same answer for semaglutide also, madam? Say, is it the same?
Same, the one, that's what he's asking. The new drug are the liraglutide and semaglutide, and semaglutide is available as an oral drug or as an injectable once a week, both.
Have you started using it in adolescents, Dr. Neelam?
No. I did. I think I need a little more time to understand about it, but little bit side effects are being seen. Some people have talked about pancreatitis, especially with the injectable one, and the other side effects are nausea, vomiting, and a little bit like that they are talking about. But at least in adults, people have shown 10 kgs, 20 kgs, 25 kgs reduction by using there. And I have prescribed to a couple of my pediatric adult colleagues.
Right.
And
Because it
metformin, madam?
figured in the India Today cover page as a magic pill, and a lot of it being misused also for weight loss. Anyway, I think we are up with the time. It's already 5 minutes past 9. So we will have to end this
And
session.
once again, I think an extended discussion was pretty useful rather than.
It's out the purpose. It's out the purpose. No, we wanted to know more about fatty liver from you, and it's out the purpose. And of course, we'll invite you again. And for the participants who do not know about her, she is a pioneer in liver transplantation in India, and a lot of success stories she can narrate to us in some other time in the same meeting. So thank you, Dr. Neelam, for sparing your time, and thank you all for active participation. We meet next Saturday morning again. Thank you all. Goodbye.
Thank you.